Hi, this is Alan Gassman. I'm your mediator today, or your moderator, depending upon what kind of day you're having. We're going to talk about patient care and the business of medicine. Some of you entered this through the Gassman Crotty Denicolo site. If you're a lawyer, you're going to get continuing education credit for the Florida bar. Some of you entered into it through the CPA Academy site. If you're a CPA or enrolled agent, you'll have to answer the 4 polling questions, which are very exciting, and then you'll get credit. If you have any questions today, you can go to the upside down pyramid, click on questions, type in your questions, and we will see your questions and we will answer your questions. The presenters today are 2 real live healthcare professionals. These are not talking heads. They're not people who pretend to know about what it's like to practice medicine and to comply with these rules. Dr. Singh still practices medicine decades into a career with a tremendous passion and a tremendous success in making medical practices work well, being responsive to patient care, and being responsive to economic demands and challenges. Linda Benson is not only an educator and a very talented person, but also a medical compliance officer. And they have a very now large and successful medical practice, but the passion is in teaching and sharing how to do this right. And that's why I am always so impressed with them. Another passion they have, which we will share today, is that they have actually started a licensed university that gives degrees in these topics, and they've been foolish enough to let me teach one of their courses. So this is part 1 of what may be a 5 or 10 part series. We ask you, especially the CPA Academy members, to let us know what you want to hear about, whether we're going the right speed or the wrong speed, because we want to bring you the information that you need. So Linda, I'm going to turn this over to you. You control the slides, and I'm going to enjoy the ride here.
All right, well, I'm going to go right through the beginning of this, and I'm going to let Dr. Singh go ahead and do the introduction to this first part 1 of the series that you let them know about. Dr. Singh?
Hello and good morning. I welcome you all to the first webinar in what we hope and plan to be a series of webinars on patient care and the business of medicine. And the approach basically is to understand the financial and regulatory environment that we are facing in the healthcare lines of businesses, especially in primary care or managed organizations or organizations that deal with managed care, IPAs, independent physician associations, ACOs, or accountable care organizations, to not only look at the regulatory and financial environment, but to look at all, hopefully, federally funded healthcare programs. Today, we'll start with Medicare Advantage. And the idea is to look at 2 main, most important models that we've had for the longest time, at least a few decades, to look at their efficacy, to understand how they work, to see how the funding and reimbursement works in these models, what is the basic organization, the decision making that needs to happen, patient population selection, and how you as professionals can help the doctors or group of doctors or the managed service organizations or even health plans. So Linda, let us begin. Let's start with the first slide. And essentially, I think the most important thing is to look at what kind of models do we have? What kind of paradigms? And there are two main approaches. One is fee for value, and the other one is fee for service. Fee for service really means exactly what the term implies. The physician provides a service and gets paid for it by the payer. In this case, we are talking about Medicare or the health plans, which are the conduit for Medicare. Linda, please stay on the first slide. Let me just go back.
Okay.
And fee for value is the other approach where not only are you getting paid for the service, but what value are you bringing to the patient, the healthcare system, the population? And the moment we say that, a far bigger dimension or many dimensions open up in taking care, in the care of the patient, where we are talking about team-based approaches, we are talking about holistic models, continuity of care, concentric networks. So in the width, in the breadth, temporally, spatially, across populations, the fee-for-value model becomes important. Obviously, we're going to talk about what kind of funding there is, and of course, in managed care, what are the things we have to do and look for. Next slide, Linda. So traditionally, as we talked about fee-for-service, it's also known as traditional indemnity insurance. Original Medicare, and even now when we have straight Medicare or Medicare with a Medigap insurance, that's what we have. Commercial insurance, workman's comp, most of the time are still following this model. And the way I try to explain it when people get confused is like you're going to Publix. Go to Publix, you pick up an item, or any retail store, you pick up an item, you're coming out, you pay the cashier some money. Now, if we remember this model, this retail model, healthcare differs a little bit, as I'm sure most of you are aware. The patient goes to the doctor provides a service, whether it's a visit or a procedure. Patient leaves, and then most of the time the doctor has to bill for it and then wait. The wait may be 30 days, 45 days, 60 days, and sometimes forever. So we will talk more about it. Fee-for-service is a method in which doctors and other healthcare providers are paid for each service performed, and this is a very important phrase, regardless of the outcome. The next slide, Linda. And fee-for-service, again, the claims are submitted as we talked about. They may choose to submit them electronically or use a clearinghouse, or even in the old days, or even now, some of them, they send paper claims. And you have to send ICD-10 codes, which gives the diagnosis, and the CPT code, which describes the procedure. And these are standardized. If the codes all match up correctly, then based on the physician fee schedule for the reimbursement amount, the doctor or the group or the organization will get paid. And again, every year we see these fee schedules played around with, tampered with, reduced, and there's a hue and cry, and then everyone tries to adjust it, but there's always a downward pressure in this fee schedule. And most of these fee-for-service insurance companies, commercial insurance companies, definitely Medicare replacement and insurance companies, they like to follow the Medicare fee schedules. If a patient goes to a hospital with which the Medicare replacement entity has no contract, they will revert to the Medicare fee schedule. Next slide, please, Linda. So this is a polling question, which I'll defer to you. Depends on your interest, but I believe each of us, whichever field we belong to, whether it's finance, legal, healthcare, we need to know about these models. Let's see, what else did you do, Linda? What best describes you? I think, do we have to wait for this quick poll?
Yeah, we wait. We're going to wait until we have 95% of the people answering. And
Okay.
if you're an enrolled agent or any kind of accountant, you can click for CPA. Wesley, where are we? 84, 85. Okay, good. Let's go.
Forward, go.
Yep. Next slide. Oh, hold
Okay.
on. There we go.
Okay. So you might have already kind of had developed a sense of what the problems with fee-for-service model are. Of course, it's reactive. If a patient has a problem, he or she goes to the doctor. I have a sore throat, I have back pain, I have chest pain, and the doctor starts taking care of it. And when the patient is done, the doctor is done, they leave, goodbye. Wherever the patient goes, the doctor does not follow up. It is not his responsibility, though a conscientious doctor will or should. But most of the time, 95% or more, these patients will go on their own. I write the orders. I write for an X-ray. I write for an EKG, or I'll do it in my office if I have it available. I'll order some blood work. I'll make a referral to a specialist or a procedure, and then I have no idea until the patient comes back, maybe 3 months later, 6 months, 2 years, 10 years, or never. So this is a reactive model. This model does not have a continuity of care. Patient must be seen, and nowadays we are allowed televisits, so you can see them on televisits, although the rules keep changing, and a service must be performed, either a visit or a procedure. So again, it's a perverse incentive, because if I have an incentive to do things and I get paid for doing things, then I will do things. If I have a hammer in my hand, everything will look to me like a nail, and that's what happens. Unfortunately, sadly, this has happened in the past. We kind of get biased in the favor of doing more procedures. Patients get biased in the favor of doing more procedures because often they don't have to pay. The physician does not take a hit, but eventually all of us, the whole society, the whole nation takes a hit, and the program takes a hit. Over treatment, and there may be under treatment, obviously, because there's no continuity of care. I'm not responsible, since I don't get paid to follow up the patient. My nurse, my medical assistant does not get paid. I don't even get paid to make a phone call the next day or have a chat with the patient. Then I have no incentive. Only if I'm extremely conscientious or concerned or caring will I do that. There is no fiscal oversight in fee-for-service. No one is watching. When no one is watching, then everyone is playing, which will often lead to poor utilization. As we have seen across the country, we are seeing increased utilization, and it is something that the Medicare administrators, decision makers, thinkers have not been able to control. Of course, our financial resources are limited, as we know. Providers have little or no reward for delivering holistic and value-based care. If a patient's A1C, hemoglobin A1C, which is a measure of their diabetes control, if it is 9, which is a poor control, versus if it's 6, which is good control, it doesn't matter to me because I'm still getting paid the same amount for a visit. If I use evidence-based medicine, it doesn't matter. I'm not incentivized to do the right thing. Incentivizes doctors to order unnecessary tests and procedures to generate more income. I'm not saying that doctors do it, but it is a misalignment of incentives. And of course, it has led to and is leading to an increase in overall healthcare costs over time. What are the other problems we have with the fee-for-service system? Congress, of course, adjusts and edits the physician fee schedule every year. We have a hula baloo. By the end of the year, doctors are up in arms, lobbyists are called, politicians are called, and they make phone calls, and then somehow miraculously it gets adjusted downward, a little bit of reduction, not too much, and everyone is happy. Providers are forced to see more fee-for-service, patients to keep up with the fee schedule cuts. Of course, it's an assembly line. If you see more, you make more money, and we see that this incentive in several practices where the physician who's hired is supposed to see 25 to 30 patients a day, and we see that whether RVU measures, whether physician service is measured, how much should they get paid. In various organizations, almost all organizations, they're expected to see a certain number of patients. No one is asking them to see a patient with quality. Everyone is asking them to see more patients. Congress controls the payment amount. There is no management for the use of resources. Patients are free to take their business wherever. and providers have no incentive to control costs. So, unfortunately, we did not achieve quality with this model. We did not achieve a reduction in cost. America, the US, spends more money on healthcare than any other country in the world, and yet we cannot say that we have the best healthcare system in the world. We are probably not even among the top 10. The question then is, how can we reduce healthcare costs, bring it down without sacrificing quality over a large population? And what are the factors that we can work on? So, excessive usage of low value care services, patient expectations, they have minimal amount to pay, so they want everything done. They're afraid, they read too much. Dr. Google is helping them to diagnose problems, and they come with all kinds of strange syndromes that are happening in Africa, Ebola, and this new virus that no one knows about, and they want all testing done for it. Established clinical practices, workflows are directed towards pushing more and more people through the system. There is an information disparity. Basically, our healthcare system is broken and diffracted. It's all over the place. There's no communication. There is no sharing of information. Patient goes to one hospital, goes to another hospital, and they'll do the same tests again. There's a great fear of malpractice, which I'm sure you would know about, which is not a very good environment for practicing evidence-based medicine. Low value care represents those services that offer no benefit to patients in specific clinical scenarios, yet may cause harm because of adverse effects or complications. The number 3 cause of death, mortality in our country is iatrogenic, caused by the healthcare system. Think about it for a moment. We could improve our mortality immediately by shutting off the healthcare system the way it is. And there have been studies. Israel, there was a few years ago, there was a shutdown in healthcare, and immediately mortality and morbidity improved. So it is a very pointed reminder to where our healthcare system has taken us. It is not the fault of the provider only. It is not the fault of administrators only. It is the model itself that is defective. So let's see if there are other models. I guess you have a polling question, so I will let you answer that.
Okay, how long have you been in practice? A, less than a year. B, 1 to 5 years. C, 6 to 10 years. D, 11 to 20 years. And E, more than 20 years. Once we have about 85 or 90%, we will go to the next slide. All right.
All right, Linda. So let's talk about this low value care services. How much wastage is there in the system? The estimates range from 10 to 20% of health expenditure involved. I think it's much more, but that's just my personal opinion. Let's take a look at some of the examples. Running lab tests when they don't need it, doing CAT scans for lightheadedness, EEGs for a headache, use of branded drugs instead of generics, performing surgery when physical therapy could be equally effective, inappropriately prescribing antibiotics which cause their own side effects. These are just some of the examples of unnecessary procedures that we do. There are standards. This is part of our quality criteria. One of the biggest challenges is end of life cost. Last 30 days, 45 days of a patient on earth is the most expensive in the system because no one wants to stop the train. No one talks to the patient because that does not pay. Communication between the doctor and the patient, setting up the right expectations, is not of paramount importance, although you would think this is one of the most important things. And that is why we not only cause more pain to our patients in their last days, we do not improve their quality, we do not improve our communication, we do not help them plan for their family or their friends when they're no longer on earth. There's no probate, and all this is considered nowadays bad quality of medicine, and that's a welcome change in our approach in managed care, and we will come to that shortly. So what is a health maintenance organization? And it really, again, the word is quite self-explanatory. You're beginning to maintain, and I sometimes feel like it is trying to maintain the health of the organization itself. It's not just the health of the patient. But the goal was to enlist the individuals and institutions who wanted to reduce the cost of medicine. And actually it started with commercial payers, like I think even Sears was involved 50, 60 years ago, and they tried to reach out to doctors and try to pool all their patients together and try to apply the treatments, the preventive therapies, prophylactic approaches, so that they could prevent conditions. And here it is no longer reactive. And basically the approach was, how can we utilize our services and improve quality care? Now it seems kind of contradictory. How do you reduce cost and still improve the quality of care? But studies have been done. Barwick and Nolan did remarkable studies on this, which showed that quality, when it is spread across a population, does reduce the cost of care. So if we can remember this concept, that improving quality will reduce the cost of care when applied in the right model, then it becomes clear. And that is the fundamental significance of fee for value.
There is, and I just want to interrupt just for a moment. There is a slide that was supposed to come in before we got into managed care. I have it in front of me, and we will, of course, provide it to you in the final slide deck. But before we get into managed care, we wanted to go over some finance and process keys for CPAs working with their clientele in healthcare as it relates to the fee-for-service model. We've looked at what it is, what the problems are with it, and where we're going. But in the meantime, there's a very large part of the medical providers who only see these fee-for-service patients, and they are clients of yours. So since the fee-for-service is a reactive reimbursement system, it's concurrent to the services that are being provided now, which means that financial planning for both business and personal can be in real time and reactive to current practice functions, scheduling, and abilities to provide specialized services. Remember, the more services you provide, the more money you make. And because of what's happened with the physician fee schedule over time, physicians are having to, today's fee-for-service physicians are having to see many, many more patients just to make the same money they made 10 years ago. And you, as financial advisors, CPAs, financial advisors, for both business and personal, should be cognizant of what that looks like from your client's side. So decisions on equipment purchases and training to use that equipment has to be based on the ROI, and that can be utilized if it's utilized properly and the right things are being done for the right reasons, and the ROI is there, then that can improve the bottom line of your clients. And since the fee schedule continues to shrink, maybe you would be able to help them with better control over costs and overhead, which must be considered. Since the government's not controlling it, we have to control it at our end, and you provide a major service with that. And then the final thing that I feel is really, really important is that coding and billing, along with accounts receivable, have to be closely monitored. And they should be done by skilled coding and billing personnel, not Aunt Sally. So this is something, or cousin Jared, or whoever it is. These are things that I feel, working a million years in healthcare, because I'm the old lady of the group, and I've been in medicine since dirt was new and I chose the color. But these are the kinds of things that I see that you as financial planners and CPAs can help your clients with if they continue to work within that fee for service, which is now becoming the fee for value model. And now I'll turn it back over to you, Dr. Singh.
Okay, thank you, Linda. Thank you for those pointers. Let's try the next slide. Okay, let's talk about, we've talked about why HMOs were set up. A bigger global view, a 360-degree view of healthcare started seeping into our understanding of managing patients' lives and health. Over the last 50, 60 years, some welcome changes have happened. And of course, we talked about quality. That has been a wonderful thing. Prevention has become more important. And if we can, of course, look at predictive analytics nowadays with new technologies, if we can predict certain conditions, reduce those factors, then we can do our health system and, more importantly, our patients a whole lot of good. Compliance has come into healthcare. So suddenly we are held responsible for what we document, and the organizations have to be responsible for how that documentation is converted into a bill, because that documentation is technically not only a legal record, but also the financial record. It is actually the bill that CMS looks at eventually. Evidence-based medicine has become more important, patient engagement and patient safety. So these are some welcome changes, and they have not come in 100% yet, but the idea has come into the system, and that is actually the real goal. If we can design it appropriately, our managed care approach can become extremely helpful all the way around. So let's talk about managed care. It has now become the most common form of healthcare in the US, especially in the Medicare population. There are various kinds of organizations, each with its own financial model. The PPOs, the HMOs, or point of sale care. Point of sale care still is similar to fee for service. PPO has much more freedom to the patient. Health maintenance organizations are the most concentric in their network, means the network is focused, and the patient has less options to go outside the network unless they need a procedure that cannot be provided by that network. Now, the disadvantage to be in a network is that you do not have the so-called freedom of choice to go anywhere you like, but the advantage is the communication in the network is better. Hopefully, it's better managed, and you have a better control over who your providers are, and the communication can be done well. And in a well-managed setting, a patient can have the best of both worlds. They can have freedom within the network where if the physicians are chosen for their quality and skill, then the issue of not getting withholding care or not providing them the best care becomes moot. These are then the challenge becomes a little different for managed care. The challenge is how to communicate with the patient, make them understand the model so they can use it to the best effect. And then when it's not appropriate to them, there has to be the flexibility to allow them to seek treatment outside the network. Again, there are regulations about it from Medicare and from CMS so that the patient safety is paramount, and we have to be cognizant of those compliance requirements. So in managed care, there is the concept of a gatekeeper. So a good primary care physician or a good MSO helps in this role. But essentially, it comes to the primary care physician who can make the clinical decision where the patient needs to go. Can the patient's blood pressure be handled right there in his or her office? Or is there an issue where they need to see a cardiologist or a nephrologist or an endocrinologist, various specialties where other problems in the system, in the body, could be causing the issue or the medical concern. So the gatekeeper function has been much maligned over the years because, again, it has been abused in some ways. But the guardrails kept for our patients to ensure that quality is measured, that their assessment and their appreciation of the kind of service being provided is measured. And then just yesterday we had the star ratings released, where 60% is really based on healthcare outcomes and the customer appreciation of the healthcare services. The patients, of course, have choice to choose their carrier and the benefit design. There are various designs in each health plan. The success of the model leans heavily on the physician-patient relationship, and this is a very important statement. The deeper the engagement, the easier it is to ensure quality, to ensure the right use of the network and the services, and to ensure the best outcome. Funding of the program is, of course, based on the documentation by the physician. So if I have a patient who's very healthy, Medicare will pay less. If I have a very sick patient, then I will get paid more. In the older days means what? 10 years ago, 15 years ago, this was fixed. The amount that the health plan got for each patient was fixed, did not depend on the sickness of the patient. And again, there were abuses, cherry picking of patients, or what I call lemon dropping. If a patient was very sick, the doctor wanted to get rid of them, and we saw some horrendous steps taken by the doctors to get rid of those patients. Obviously, there are more protections now. Physicians may not discharge their patients if they're on the managed care panel, unless they have a clear reason and it's approved by the healthcare plan. So Medicare risk adjustment is, again, it adjusts for the risk, means the sicker the patient, the higher the premium, depending on the age, the sex, socioeconomic status, the ethnicity, the geography, and probably the most important, the disease status. Sicker the patient, more the funding. And in some ways, if you have a good doctor who knows how to take care of sick patient, who does a good job, they can do a great job for the panel and save the panel a significant amount of money. We have another polling question, so I'll defer that to you, Alan.
Okay, which of the following best describes your practice? A lot of you are going to answer, I do not actively practice medicine. But if you are a medical practitioner, besides thanking you for taking care of us all, we ask you to tell us, are you solo, group, university teaching, not-profit, or retired? And by the way, while you're answering this, I will mention, if you have an indemnity type practice, or you're selling it or buying it, you're recommending to this practice that they have their charts reviewed to make sure that what they are billing is proper for what the patient needs, and that their chart notes are supporting the billing. Now, your clients who have practices that are management organizations, the MRA rating, where the doctor tells the Medicare or the insurance company, hey, this is a really sick patient, I need to get paid more than average, that needs to be audited to make sure that the doctors are doing that properly. So if you're a CPA or financial advisor, you really want your medical practices to have independent consultants come in. Commonly, or most often for my clients, we hire the consultant because we want to keep it under the attorney-client privilege. The consultant comes in and reviews 20 random charts, If these are fee-for-service patients, we want to, see one thing. If they're HMO patients, we're looking for another thing, but nevertheless, it needs to be carefully reviewed no matter what kind of client or patient situation you have. And the result of a good consultant review will be not only reducing risk and spotting issues, but finding ways to make more money. So Dr. Singh, I hand it back over to you.
Thank you, Alan. Those are very important points. I think one of the reasons for our successes is to involve people smarter than we are. Doctors are very intelligent people, but in their own field. They have a tremendous skill. I have spent, more than 27, more than that now, 38 years in healthcare. I've not spent a single day in my legal practice. I've deferred that to people who know much more than I in the legal field, and the same goes for finance and accounting. And auditing is not only important nowadays to keep the doctor safe or to make more money, but also if there's a long-term plan for a monetization of the practice. If you're someone is planning to retire at some point or sell the practice, there will definitely be an audit. If you look at some of the big practices that have gone bankrupt, one of the practices just sold its 2 states to a health plan, and it's all public information, so it can be looked at. Unfortunately, they've found grievous errors of omission and commission in that. Auditing missed a lot of proper documentation, and this can really spell the end of an organization. So this is something that cannot be taken lightly. Education is the most critical thing, and doctors need great mentors. And of course, that's why this is such a beautiful thing that we are sharing our knowledge both ways. So we learn from you, and we are happy to share what little we know. So Linda, let's talk about Medicare risk adjustment, and very briefly, let's talk about the doctor. From my end, how do I get paid if I have a Medicare risk adjustment panel? Suppose I have 1,000 patients. Usually, and of course, depending on the contract, usually I would, if I'm wise, then I will not sign a fee for value contract. If my practice is capable of managing managed care patients, then I will sign a capitation contract, which means I will get a certain amount of money per patient. So it used to be about $50 per patient. Some plans pay $55. So think about it for a moment. If I have 1,000 patients, Medicare Advantage patients in my panel, I get $50 in cap. I get $50,000 every month, first week of the month, usually up front. I do not have to wait 2-3 months for billing. I do not have to worry about rejections, denials from the health plan, and my overhead is taken care of if I have a significant panel. So this takes pressure off of me. The second thing I can do, if I'm wise, again, if I have good consultants who are helping me, I can do a partial risk contract, which means I can get bonuses if I pursue quality, if I've provided good numbers in metrics in quality, in compliance, in documentation, in patients' perception of the healthcare system. What kind of services are we providing to them? Do the patients perceive they are better off? This is the question that CMS asks. Do you perceive that you're better off? And these are the interviews and data that is collected by various organizations for CMS. So if I do a good job, I have great quality, I help the health plan with 5-star ratings, my patients are all happy, then I get additional bonuses in quality. And this quality can be by each service. It can be for stool cards, it can be for hemoglobin A1C for diabetes, for a urine test, or it can be an overall package that if I reach a certain score, I get a certain amount of money. And then the third level is risk taking. When I take a partial risk or a full risk, means if I save money to the panel, then after certain admin fee and certain charges, the health plan is willing to share its savings with us. Now, again, this is a two-edged sword. If the doctor knows what he or she is doing, then they can take advantage of it. If their practice is ready for it, if they are mature, if the panel has been worked on and the patients understand and have a good relationship with the doctor, then the doctors can make extra money on this legitimately, compliantly, and by achieving good results. If the doctors are not ready for it, if they're unwilling to learn or unable to learn, do not have the skill set, or their practice is not ready for it, or the patients are not prepared and educated for it, then they can lose money. And I've seen people lose a significant amount in their lives and causing significant risk to their practices and to their own personal future. So this is important to understand. And again, Alan's caveat about making sure you have good mentors is critically important. So CMS, let's talk about the Medicare Risk Adjustment Plan. Now we're talking about CMS perspective. CMS will take a patient, suppose the patient has a certain age, certain sex, and lives in certain geography, certain ethnicity. So these are factors which will give this patient a certain amount of premium. And then based on their disease conditions, which are usually called HCCs, these are the hierarchical conditions, categories of conditions, and CMS has them released. We can make sure that the physician is educated on these. Based on these, the premium is set up. Now, CMS traditionally has Part A and Part B, and then Part D, which probably we can discuss if there's any question about it. But this premium goes to the health plan. Health plan will charge a certain amount of administrative fee, will either pass on some or all of that premium to managed service organizations or IPAs, who will then manage their affiliate physicians or wholly owned physicians. So Linda has this beautiful diagram, which is actually a very simple bucket. The money coming in is based on MRA. CMS decides, looks at all the data. And this is an important diagram to remember. Based on the diseases, the HCCs of the patient, the funding will go up. Based on the utilization on the right side in red, based on Part A, Part B, patient goes to the hospital, patient goes to the nursing home, sees a consultant, has a procedure done, X-ray, radiology. And then Part D, if they buy any drugs, all these are expenses, and the money for that comes from this bucket. We want to make sure that the MRA is adequate, is compliantly done, but you catch all the diagnoses that a patient has, which is why a practice must be mature enough and the staff educated to make sure all the data is captured. And then utilization on the right side, the red arrow is the challenge for our nation. This is where we have not been able to control the costs, and when all these expenses are happening, traditionally this is what is out of control. To control this, of course, the staff have to be more educated. There has to be a better engagement with patients, but also the use of consultants, a good communication with consultants, with the hospitalists, with the skilled nursing facility physicians, and making sure patients understand and have the right expectation of their condition. Unnecessary procedures, readmissions, wrong medications not only increase mortality and morbidity, they also create a burden for our system, whether it's fee for service or whether it's fee for value, and wastage is never good. So one has to be aware, everyone has to be aware of each resource being valuable, and the attitude should be, how can I optimize the resources available? Let's look at the next slide, Linda.
I'd like to take this slide, if you don't mind.
Go ahead.
This is a comparison of fee-for-service for MRA, and I think what's important to understand here is that fee-for-service as a reactive model is a reimbursement model. You see the patient, you write the note, the codes go, you get paid if everything is good. Medicare risk adjustment is a funding model. It doesn't matter how many times you see the patient or what you do, It is a funding model. So it works completely differently, and that's something that I think we must make sure that everybody understands. So let's talk about the similarities first. So in both models, the progress note is the bill. Not the super bill, not the electronic file transfer. The progress note is the bill. If a payer wants to know what happened on that date of service, they ask for the progress note. They don't ask for anything else. And that note has to tell the story of what happened that day. So for the reimbursement model, everything has to match up, and the note has to be clear, and it has to be a total stranger who doesn't know you or your patient has to be able to understand what happened so that there's no denial or whatever of payment. On the MRA side of things, it's the same thing. The payer is going to ask for the progress note to see what happened. Again, a total stranger has to understand what went on, why you did what you did, why you didn't do certain things, why you reported certain diagnoses, were they supported, so on and so forth. They both use the same code sets. The CPT set, which I call the what did you do, how many did you use, what happened, and ICD-10, which I call the why did you do those things? You wouldn't send in a code for a sprained ankle to cover an EKG. Those codes don't match. So that's where coding comes in. You have to make sure that whatever written word is on the progress note is translated into the CPT and ICD-10 codes properly, or there's going to be problems down the road. So again, fee for service is reactive. You have to see the patient. The more services rendered and billed for, the more revenue. No one's controlling the spending. Patients can doctor shop or hop all they want. If I don't like what Dr. Singh has to tell me, I can go to Dr. Smith next week, do all the same things all over again. Following week, do the same thing with somebody else. Not good for the patients because it increases their risk. They're being exposed to all kinds of things while they're doing this. And a patient needs to hear what a patient needs to hear, not what they want to hear. So that's another aspect of a fee for service that maybe some people don't take into account. Patients will go and keep going until they find someone who'll tell them what they want to hear, not what they need to hear. Not good health care. And again, because the physician fee schedule is shrinking, doctors have to see many more patients and do much more today to make the same money they made 10 years ago. And quality measures are voluntary. Now that's changing because the government recognizes that fee for service is very broken, and they're moving towards fee for value, which managed care or MRA is one approach to. So when we talk about MRA, we need to understand not only is it very different in how the money moves, but it's more of a preventative model of medicine. And to me, I'm going to get on my soapbox now, it's a much better model of medicine. So progress notes the bill, uses the same two sets of codes. However, in MRA, it's the ICD-10 codes that determine what the funding is. And why? Because each code carries a weight. Each healthcare an HCC, a hierarchical condition category, carries weights. And those weights are added together to predict the patient's risk of morbidity or mortality. And that's why the higher the score, the more funding. And that becomes very, very important for many reasons. It's a predictive model. What we're documenting today is going to tell us what the funding is next year. What we're being funded for right now is based on what we did this time last year. So it is a predictive model, which for a financial planner, CPA person, changes a little bit what your relationship with your client is. Your whole planning is different. In this predictive model, the PCP controls the resources. We already know that the patient chooses the insurance company, the benefit plan that fits them, and then their PCP, and that's it. The rest of the care goes through that gatekeeper, and the patient-physician relationship is huge because if you want to change a patient's behavior, you have to have their trust and a relationship with them. It rewards good preventative care and patient management. And then there's the 5-star quality system, which is mandatory. And the insurance companies want 5-star for 2 very good reasons. One, if you're a 5-star company, you get to take new patients 365 days of the year instead of being stuck with the little open enrollment period that we just entered. And additionally, the higher your stars, I think it starts at 4 stars, up to 5 stars, you get more money from the government. So now that money has to be used in your benefit package. Now I'm a patient, I'm looking for an insurance company. Do I want the benefits from a medium pizza, those slices, or do I want my benefits from the large pie with the very large slices? I'm a patient, I want a 5-star company or someone who has better benefits. So major takeaways from this particular slide: fee-for-service is reactive. You have to see the patient. You have to see so many that you can't do good preventative care. Quality is not as important as it is in Medicare risk adjustment. Medicare risk adjustment is a predictive model. That means something to everybody who's in this particular model, that things that we do today are going to affect us next year. And I'll just turn it back over to you, Dr. Singh, but that's.
And by the way, can we leave 5 minutes for, can we leave 5 minutes?
Yes.
Leave 10 minutes.
I think what I'll do is probably I can stop now unless I have more time. How much time?
No, we have plenty of questions, so.
So I can stop here, and then questions will often clarify things better. And we can always continue this further if we,
I think this is the last slide before we go into that. This is the last.
Okay, let me finish. Okay, let me finish it. So gatekeeper policies, some limitations we talked about. It can be abused, and so Medicare has put in more restraints on the gatekeepers, which are good. And any denial of care is not done by the physician; it is done by the health plan. Financial incentives can be misaligned with non-compliance, and that's again something that the federal government is cognizant of, and they make changes which they have done for next year's funding. And then guidelines require adherence by the providers. If there's non-compliance, plans will drop, and managed care organizations are required to do review of services, and they are the ones who do the denial of payments based on certain ODAG regulations or CDAG regulations, which we can talk about someday. But so I'll end here because questions are important, and Alan, I hand it over to you.
There is one more slide about finance and process keys, like the one for fees for service. There is another one for MRA, and we'll go into it now, but you will have it in your slide deck, and it goes through specifics that CPAs, financial planners, need to be aware of and are important for you to discuss with your clients. That will be in the updated slide deck.
We can discuss it next time. I think I'll defer to you, Alan.
Right. Okay, one question here is, do I need to be concerned that if I need an expensive procedure or treatment, I won't get it because the MRA doctor wants to make more money? And what is stop loss insurance?
So, okay, let's talk about these two things. Expensive, so most patients have rights, and patients are very cognizant of their rights now. And the question is, the way I hear it is the procedure appropriate and relevant? Is the medical reasoning behind it appropriate? Sometimes we get requests for procedures that are inappropriate or cosmetic procedures. Those are usually not covered. And there are whatever Medicare covers is covered by these Medicare Advantage plans and policies. Is there abuse? Yes, and that is why it is critically important to pick a doctor who has good ratings, with whom you have good engagement, and you make sure you do your homework and reference check on them. Reinsurance is something that health plans will buy on catastrophic cases, but also MSOs, IPAs will buy, or physicians with big panels will buy. And again, there is nothing that is totally risk-free. The moment you say risk means if a practice is not prepared for these fluctuations, they can get hurt significantly.
Perhaps
Okay.
we need to do something on that, you know, a topic on that.
Right.
In the future.
That's a big, yeah.
So another question is, this seems to apply mostly to primary care medical organizations or medical organizations that have a lot of primary care doctors. What does a specialist do?
So specialists can get capitated too. Specialists are doing fee for value too nowadays. We are seeing orthopedics networks. These networks are coming more and more. You might have heard of radiology partners. They try to do something like that. We are seeing this in dermatology, cardiology, oncology. One of the big companies, I think it's called the TOI, they're trying to bring fee for value for patients where they have a certain amount per member per month and they manage these patients within that amount. So more and more fee for value is becoming important even for specialists. It's important to know there are certain challenges with specialists doing it, but in California, this is actually not unheard of. Actually, it's quite common.
Okay, as a medical consumer, how would I pick the right HMO? And do I get to find out what my MRA score is? And where do I look to make sure that the doctor has good ratings, really, not just internet advertising?
So let's start with the HMO. Let's go with HMOs that have preferably, as Linda had alluded, 5 stars, although, you know, numbers are often can get biased and people have a certain bias in numbers, but also plans that have a good name, that are known to be compliant in the market, that have a longer standing, or even if there are new plans, making sure that one reviews who has started this plan. We have seen quite a few plans in the last decade collapse and shut down and suddenly leaving patients in a limbo. Although the Department of Health is very protective of our patients and consumers, so they jump in right away to make sure our patients are safe. But yes, we have seen several plans that have gotten shut down and creating a huge problem. So definitely pick up plans that are strong, that have good star ratings. 5-star rating is not everything, but it tells you a little bit about the plan. At least they're organized with their numbers. But any plan 4 or above is a better plan in their management.
Also, the NCQA accreditation for health plans is another indicator that you might want to look at. So if it's an accredited, healthcare plan, it's gone through NCQA audits and met some pretty strict standards.
And same with doctors. You can, I know these ratings are cooked. I'm aware of it, but sometimes a good doctor will be willing to sit with you if you want to interview them. They used to interview me. My patients would come and interview me. Used to do that. And then, of course, hearing from word of mouth or talking to other patients always helps. But a good research is always a good thing. What are the degrees they have? How do they talk to you? Do they sit with you? Are they respectful? Do they listen to you? The manners, the etiquette, it does tell you a lot because that is very important. What is your MRA? You have a right to all your diagnoses, what the codes have been used for you over the last, whatever time you have been with Medicare, and that is your right, and you have access to those codes. If you want to know your MRA, I'm sure Linda will run your codes through her MRA calculator and get them for you.
Okay, then there's one last question I think we can cover, and then we need to do the last polling question and say goodbye.
Yes.
What is Videri Institute?
Videri Institute is it's okay. It comes from the word vid, which in Sanskrit means knowledge or wisdom, or Latin vide, which also is to know. You might have heard of Caesar, Veni, Vidi, Vici, or the word video. That also comes from this ancient root. And our goal was to create a platform where education becomes available across the globe, bring the best consultants and transfer our knowledge to anyone who is seeking to know without the limitations of distance or their ability to pay, but also to create the best knowledge system that is available so that we can develop new leaders in the future and hopefully and contribute to a better society and a better world. So that is Videre. Alan, it's all yours now. I think we've run out of time.
Yeah, let's just go to slide 39. Last polling question. Would you like to see a part 2? Yes. You can click yes, no, or I'd rather have a spinal tap. Now, if you want the spinal tap, you can use an indemnity insurance policy. So the doctor can get free. What percentage are we at there, guys? 88%. 88% of the people are awake, and the last 12% waiting for them to answer, and we are finishing exactly on time, except if you're in California, you're finishing an hour behind. All right.
Thank you.
Well, thank you so much for that great presentation, very educational both as a counselor for doctors and medical practices, and as a medical consumer and as an employer. These are really, really important things, and really appreciate how long the two of you have worked together and how many thousands and thousands of lives you've impacted positively, as I well know. And I'm one of them. So thanks again. There are a lot of questions we didn't get to. I'll be emailing those to Linda, and we will look forward to part 2 in the very not too distant future. Thank you.
Thank you.
Thank you. Bye.
Take care.
Bye-bye.